Next, we're going to move on to Dr. Salem. Dr. Salem was introduced yesterday, but for those of you who don't recall, he's a graduate of McGill, and he is currently the Director of Interventional Oncology at Northwestern in Chicago, and he's going to talk to us again about the yttrium and radioablative embolization therapies. Dr. Salem.
Thank you very much, and again, thank you for the kind introduction. And what I'd like to do this afternoon is review a little bit again and remind everybody what the concept is in terms of the local regional therapy. You heard David talk about the ablative concept, and what we are talking about here, and that speaker is right in the way of either laser pointer, but either way. So what we're talking about here is a transarterial infusion of a therapy, and here I'm showing you the slides of the radiation, but essentially I do want to talk about chemoembolization and bland embolization, which are certainly therapies that have been used for much longer periods of time than the new therapy that I'll be discussing in a little bit. Now, I showed you this slide. Would it be possible by any chance to get the speaker pulled back a little bit, because I can't reach the pointer? I can't really point to the slides. So what you see here on these slides I showed you yesterday, which is basically when you think about the radiation microspheres, it is a microembolization, which means you are not blocking off the blood vessels. And perfect. Thank you very much. And this is a slide that Dr. Liu actually just sent me this morning as another example. And we see this quite a bit, and it's really a very dramatic example here. Here you can see, this is another angiogram, and you can see those dark spots are in fact the tumors. And here what we've done is we have treated the right lobe, and you can see now that the right lobe, the vessels are still open, but the tumors are gone, whereas now we're starting to plan on treating the left side. So this is treated right side, this is untreated left side, showing you a very dramatic difference, and we see this almost all the time. Like I said before yesterday, this is really sort of a paradigm shift when you think about how to treat this. Now, I wanted to add some of these slides and discuss a few concepts that we've learned over the last few years. Now, again, I showed this slide yesterday, and just to show that this lesion here that was 18 centimeter in size that was treated was shrunk and now decreased to about 6 centimeters, and in fact the tumor was then resected, and that's how you can see that specimen. One of the things that we talked about also a little bit yesterday was the concept of a biomarker and downstaging patients to transplantation. That's obviously much less common with neuroendocrine, but it happens quite a bit in hepatoma, and this is what happened to this patient here, where the lesion shrank and was in fact transplanted. Now, one of the things I also want to talk about today is enhancement of tumor. Now, one of the things we're used to talking about when you think about after you embolize a lesion is that you block off the blood flow so there's less enhancement in the tumor. One of the things we have learned is that, in fact, this may not be the case, and if you use biomarkers, like in this case, the alpha-fetoprotein, it will prognosticate that this person is going to have a good effect, and indeed at 6 months, a completely dead tumor that we were able to predict at only 1 month. So a lot of interesting things that we have observed. Now, interventional radiologists, as you've already heard from a little bit from myself and today from David in terms of the roles that we can play and how we can help in managing patients with neuroendocrine tumor. You heard already about some of the ablation here, and I'm going to talk a little bit about the other embolic type therapies. But I did want to highlight a project that we just completed at our institution of 463 patients that we treated over 10 years to really try to identify these concepts of time to progression, progression-free survival that we have not done previously. And what we learned from this exercise is the fact that we have a lot to correct from our imaging perception of viable tissue. What does that mean? This is a patient that was treated with a 6-centimeter tumor in the top end of the liver, in the dome of the liver, that following treatment looks black, which means most of it is dead. But there's clearly this nodular enhancement on the inside of it, and clinically that would make us want to go back in there and treat that patient. The problem is this patient was transplanted, and when we cut up that tumor, that was completely dead, even though we thought here that there was viable tissue. So here we had a clinical perception of viable disease, yet at transplantation, this was completely dead tumor. So we have some things to learn with imaging. And so what we did, and again, this doesn't apply to neuroendocrine, but the concept is the same because we have many more organs that we can study in what we call hepatocellular carcinoma than in neuroendocrine disease. But what we did is we wanted to correlate radiology, what we see by imaging, with actual tissue. And we did this with the yttrium microspheres and with the chemoembolization. And this is what we found, and it really echoes a little bit of what Dr. Liu was just talking about, which is the following. If you look at the pathology data of the yttrium, this is in black here, that when you have small tumors, we get complete necrosis all of the time, as opposed to chemoembolization, complete necrosis 1/3 of the time. Now let's move on to larger tumors. With larger tumors, 3 to 5 centimeters, you have complete necrosis with the yttrium 60% of the time and only 40% of the time. But as David was talking about, once you get to larger tumors, neither therapy does well, which is why we need to think about combination-type therapies. So once you get over 5, it's very difficult to get complete tissue necrosis at the pathologic level. We also showed here that the partial response rate, the amount of decrease in size, is also slightly better with the yttrium as it is with the chemoembolization, 57% versus 39%. Now, this is a slide from Dr. Cole's article in JNCCN that really gives you a very good overview of all of the response rates that we've observed in a long time. As you can see here with chemoembolization, again, chemoembolization and bland embolization, which is injection of either bland particles to kill tumor or injection of chemotherapy as well as bland particles, the combination, you really get pretty good partial response rates, and depending on the series, anywhere between 30 and 60%. This is a series here from 10 years ago on 41 patients that we're discussing and was published in Cancer. And the partial response rate here was about 52%, so very, very good partial response rate. And with a, if you look here at the PNETs here, pancreatic neuroendocrines, 50% partial response rate. And interestingly, the duration of effect of about 10 months, which is a little bit what we were reporting yesterday, a time to progression or maybe even a PFS of about 10 months. Now, Tom Vogel and his group from Germany just recently published a very nice overview that really looks at all of the ablative type therapies, including laser interstitial thermotherapy that's not available here, and the embolics that we are talking about. So this is really sort of a nice review if you want to take a look at what people have seen. And they displayed things very nicely, talking about using the embolic type therapies in symptomatic or asymptomatic, essentially following the algorithm and showing that some type of local regional therapy in the liver will almost inevitably be needed. And here they go through the rationale behind each one of these therapies and what you are looking for from a clinical benefit standpoint. Symptomatic response, biochemical response. You heard about all the biochemical issues and response that we can use here. Morphologic response, and of course, very important, the survival time. So very nicely go over that entire rationale. Now, also Dr. Liu published this article a few years ago, really going through almost everything he talked about today, and I'm talking about today here in the American Journal of Clinical Oncology. And if you want sort of a very nice overview of all of the aspects of local regional therapy in neuroendocrine, this, I think, is one of the landmark papers. Now, people have evolved in terms of embolic type therapies, and now we use something called drug-eluting microspheres, where you now inject and you block off the blood flow, but now inject much more concentrated chemotherapeutic product here. Here we have a 20-patient pilot study from France, from Thierry Deber's group, where again they were able to get very high partial response rate. Now this is again only at 3 months, very much able to get very high shrinkage and able to kill tumor. Now the problem is it's very difficult to correlate that with pathology because we have very little resection. Most of these people have been resected before and embolized after. Here's an example of a large tumor, as you can see here, following treatment, a significant reduction in size. It looks almost dead, but a very nice result here now with embolization with drug-eluting microspheres and doxorubicin. Let's move on now and talk about radioembolization, the yttrium, and talk about the most recent data. The largest series here is something we collaborated with Andy Kennedy on 150 patients or so treated across 10 centers in the United States. Here you can see the variety of primaries that were treated. So this is really sort of a pooling of data from multiple institutions to look at what the outcomes would be. And again, notice a very high, again, the recurring theme of very high partial response rate here, 60+% in this 150 patient series with over 7-year median survival from time of first treatment. Another series here that we published in Annals of Surgery on 42 patients that we treated, very high partial response rate here. If you look at disease control, 92 and 94%. And this is a new example of a patient with a very large tumor in the left side that was not a surgical candidate, was treated once to the left lobe with significant reduction in size following treatment. So one treatment with this kind of therapy can get some very dramatic effects. A very small pilot study here from Germany that was published on patients that were treated with, again, similar time to progression that we are reporting compared to other studies. But one of the interesting things that I thought with this is they were displaying their response rate by time. And if you notice here at month 9 to 12 or so, where you start to have some progression, this essentially parallels the increase in chromogranin at about month 6, 9, 12 or so, as you can see here, and quality of life score that they used to look at these patients. So very interesting that some of these imaging findings were being paralleled by changes in quality of life. Some recent studies, this is from the group in Australia, Lawrence Bester and David Morris, published a 48-patient series here as well. And again, notice that most of these patients have had multiple surgeries, embolizations, chemotherapy, etc. And this is where the data is. And this is a mean tumor burden of about 30%. We talked about that a little bit in terms of what tumor burden would be optimal. But again, a lot of these patients had previous chemotherapy, and here we have about a 55 partial response rate. So again, mimicking some previous series. Sorry, these slides are formatted a little bit differently, but again, I just wanted to show that many of these patients are getting probably more standard therapies such as resection, ablation, and probably embolization is probably more widely practiced worldwide than Y90. But again, these patients have been exposed to previous therapies prior to treatment. In this series, these patients were getting infusional 5-FU with treatment as a radiosensitizer. So this is interesting, where we can start to think about combining these kinds of therapy, the radiation and chemotherapies that will make tumors sensitive. Here we had a partial response rate of about 40%. And if you look now at response versus non-response, you can sort of plot these two differences. You can see that the responders certainly had a better outcome compared to the non-responders. And just to close up on a new idea that actually we've done in a couple of patients now is something that we don't have a very good name for, but there are some patients with neuroendocrine tumors that have multiple liver tumors that will require removal of the primary in the form of a Whipple procedure. A Whipple procedure will involve an anastomosis of the bile duct that then makes liver-directed therapy a little bit more risky and infection a possibility. So what we've done in actually only 2 patients at our center is in those patients that we think will need a Whipple procedure, we actually have treated the liver disease first. Here you can see a patient where you can see with those tumors, those dark tumors lighting up, and we treat the patient before the Whipple. This way we mitigate any risk of infection in treating the liver on a patient who's had a Whipple procedure. And you can see a very dramatic effect. All of these tumors here, most of them are gone. There's only 1 or 2 here, as you can see in the dome, but a very dramatic effect. And this way you can eliminate the infectious complication that might happen in patients that have had a significant pancreatico-biliary surgery. So to close off, this is clearly new therapy. When you think about the Y90, chemoembolization and bland embolization is more established, but it is a paradigm shift. When you think about Y90, one of the trials that would be interesting to see is, in fact, embolization versus radioembolization to see which one is better, which one has longer progression-free survival. We talked about clinical trial design a little bit yesterday with these kinds of therapy, but unfortunately, we don't have a lot of explant data in the neuroendocrine patient population because most patients are getting resected first, and then we tend to see them for embolization. But there certainly is a lot of work that needs to be done, particularly with the biologics that you heard about yesterday. And with that, I'll end my talk. Thank you.